the person who will take care of the geriatric point of view, the surgeon, it is called orthogeriatrics. The surgery, as per the standard, surgery should occur on before 48 hours. So if the surgery happens within 48 hours, it has a good outcome. So they just ask that what is the best outcome or what is the best prognosis. So 48 hours before they do surgery. And in the last slides, we have discussed this about intracapsular. So anything which is Gardner 1 and 2, the blood supply will be intact. So they will usually screws are being fixed. If it is Gardner 3 and 4, then of course the blood supply is gone. So they use arthroplasty, which is THR or TKR. If it is extracapsular, then blood supply is intact. So I'm talking about the head of femur. Then they use dynamic hip screw. Okay. So this point can come in question, that when to use dynamic hip screw, when to use arthroplasty, and when to use screw. Okay, I'll go to the next slide. Then comes is the shaft. If it is a shaft fracture, then it is intramedullary nail, unless it is a comminuted fracture. If it is comminuted, then they will use the, external device to, or Alizaro sort of, to support. Investigation. I remember there was one question in my exam. They asked about what is Sherrington line. So it's, maybe I have, no, it's not there in the image. So Sherrington line, for now, you just write it down, and then when you go home, you can just find out what is Sherrington line. But Sherrington line is just one curve which joins from, in the X-ray, it's like a curve from the acetabulum till the femur. So it's sort of this curve in X-ray. But if it is broken because of the fracture, then the Sherrington line will be broken. And that is one of the criteria to understand that there is a fracture. Guidelines, NICE guidelines. What is NICE guidelines? Just go through it, because we are not going to go through these guidelines in detail. But just remember what is in general, what is NICE guidelines. Weight bearing. Usually, with any surgeries, they try to weight bear immediately after operation, unless it's been said by the surgeon or any complications there, then we don't do weight bearing. Otherwise, usually weight bearing is very good for early healing. Physiotherapy point of view, I'm not sure back home do we support analgesia. But here, whenever the surgery happens and when we go to see the patient for the first time, so I need to check what is his analgesia, when did he took the pain medicine. And it is very important as a physio point of view, because today, for example, it's a day 1 or day 2. My goal is to take the patient out for a walk. And if the patient's pain is 7 on 10 or 8 on 10, I can't make him mobilize. So in exam, we have to encourage the patient for analgesia. I'm not sure whether we do ask in India or wherever you're from, but here we do take care in the file that, okay, he has taken analgesia or pain medicine at 9 a.m. So my goal will be after 9 a.m., maybe 9:30 or 10 o'clock, not 10 o'clock, 9:30, maybe after 20 minutes or 30 minutes of medicine, the physio session will start. So this is a point for exam as well as for clinic, that clinical examination, that physio should encourage the patient to take analgesia or pain medicine before mobilization. It will help to reduce the pain. Less the pain, better the mobilization. Mobilization in terms of getting out of the bed. Like, I can take the patient for a walk. If the patient is in pain, I can't take the patient, even I can't do any exercises. So the patient will be in bed for longer time. Longer the delay the movement, it will happen, there will be chest complication, or there could be DVT or any other complication. So we don't want all that stuff. So we need to encourage analgesia, and that's how some of the MCQ they ask. That there was one question in exam that the physio went to the patient for exercise, and he was under pain. what would you do? So there was one quick question, encourage for analgesia, and we have to encourage that. And do you know in cardio topic, you might have understood there are 3 types of anesthesia or analgesia. What are the different types of pain medicine? Epidural and patient control and analgesia. Have it been covered?
Not yet.
Okay, so there are different types of analgesia for patient where patient controls it. There are 2 types of analgesia where we advise. I'm just giving you is just because in fractures these things come. So there are 2 types of analgesia we do provide. First is just the patient control, and then the other one is which is not in the hand of the patient, it is already given by this drip. So usually what happens here is for example there are analgesia 15 milligrams is been required. So for example 10 milligram is already coming from the IV line, but 5 milligram is sort of it is under control of the patient. So that is called patient control analgesia. So the patient will have a button and then he can press whenever he wants to. So 5 ml dose is sort of whenever he wants to take it. So within full day, or maybe for example, every surgeon said that every 2 hours he can take extra 5 ml. So every 2 hours he has the liberty to use to press the button, and then the analgesia will go into his bloodstream. So that is sort of a question sometime can be asked, that we have to encourage that patient control analgesia. In cardio, just read about different types of analgesia the patient can take. And the second one is just the medicine. We also encourage the patient to take the oral medicine as well. Is the point clear, or am I too fast?
Ma'am, here in India, after if a patient is having epidural, we just block the epidural and we make patient walk after 15-20 minutes to avoid the dizziness or something. So over there, is it okay if the epidural is on and we can mobilize the patient?
Yeah, so that's not a problem. If it in the exam, it will usually in the clinic, it is written that, okay, he's on epidural analgesia. So if it is a continuous one, we have to ask the what you call the nurse to just stop it for some time, and then we can take him for a walk. But if it is like sometime it is just through the veins from here, so we take the trolley. Like there is a trolley, like a portable for IV. So the IV line, and it also has the BP and every machines and pulse ox and all. After checking all the parameters, we can take the trolley, and then the trolley will be pushed either by the assistant, or if you have an extra physio there, so we just pull the trolley and the patient can walk, and then we take a walk and come back. So yes, the patient do walk with the trolley as well. So it is the trolley as in, like, you might have seen the IV line, and then the IV line will be like, there will be a saline plus the stand, and then there will be some BP sort of a smaller one, the BP, the pulse ox, and then the stetho, and there will be small trolley.
Okay, ma'am, thank you.
Okay. Then the other extra point is the fracture. Stress fracture do come again in a exam. So stress fracture is like you won't see the stress fracture immediately. It is like a small micro trauma happening in the either into the head or into the neck. So commonly it is seen in the female, especially young athlete female, who does like lots of activities. And in exam, like though there will be different outcome measure, but Hop and Fulcrum test, I'm just giving you an example that Hop and Fulcrum test, when you ask the patient to hop, the patient will say that he is having or she is having pain around the hip joint. So that is one of the outcome measure. So in exam, they can ask you about different outcome measures, how you will understand how you will differentiate one fracture from the other fracture. So you have to just judge yourself that what could be how I could diagnose the stress fracture. So Hop and Fulcrum is one of the tests.